neurologist with a strong interest in how environmental exposures impact brain structure and cognitive aging. She completed her residency at Northwestern in 2021 and then completed her fellowship in preventive medicine and public health at the University of Wisconsin. She joined the faculty at the University of Texas Health San Antonio in 2023. She's one of the current RL5 scholars with the Pepper Center at UT Health San Antonio. The focus of her research is environmental exposures and impact on cognitive function and brain structure. So, Dr. Doyle, I'll let you take it away.
Thank you, and good afternoon. New afternoon to everyone. It's really nice to meet you all virtually. As Dr. Bradley said, I am a Northwestern alum, and so I was digging back in my pictures. I was like, I know I have a post-call, post-night float picture from the roof of Feinberg. So this is from, I don't remember when, sometime when I was here. Um, but I was a undifferentiated neurologist throughout residency, kind of just trying to survive it, really. But then the COVID pandemic happened when I was a third year, and I don't know why I took this picture of the New York Times headline. I guess 100,000 really struck me. But um, in addition to being really just hard, sad work at the hospital, I had a lot of time to think about how I wanted to be a neurologist. And oops. Sorry, I'm trying to hide my picture. There we go. I found that there was, a lot of neurology was kind of neurologic manifestations of end stage systemic disease, and many of which seem to have opportunities for prevention or for earlier or better treatment. And so I took an atypical path and went up to another city on the lake in Madison, Wisconsin, and did a 2-year fellowship in preventive medicine and public health. So this is a program. I think they're losing a lot. A lot of these programs are losing their funding because of the current funding environment. But it's 2 years. If you don't already have an MPH, and many people already do, if you don't already have an MPH, which I didn't, you do 1 year of coursework there. So you work on I worked on my epidemiology and biostat skills, evaluating study design, and then a year of more practical work. So again, because people come with all different backgrounds, they do different things. But I spent time working with the state health department because Madison is the capital of Wisconsin. So that was interesting to see how stroke prevention worked, coordinated with the state health department, with an ongoing cohort study that was using a novel sampling design to get at hard to reach populations. So that was cool to see that, even though addiction medicine is not my, primary area of interest. It was good learning to see how that happened. But anyway, so after, but trying to say, okay, this is fun, but how am I going to be a neurologist with this training? And right before I went up to Wisconsin, this report came out, because stroke had seemed like the low-hanging fruit, as far as opportunities for prevention, particularly vascular prevention to prevent strokes. But this report, the 2020 Lancet Commission report on dementia prevention and care came out around that time. And of course, this stemmed from decades of work. It was new information for me, but it was from decades of work from other people. But it was a splashy headline about how 40% of dementia cases are possibly preventable because they're related to these modifiable or treatable risk factors. And this seemed like an exciting thread to pull for both clinical practice and for research. And obviously, it might be kind of small, but the prevalence of these risk factors on a global scale are a little different than what they are on the US. But it seemed like possibly this was a way to marry the two neurology and public health interests that I had. So that the Lancet, so just by way of background to, these are things I've been working or reading about and gaining my skills in for the last number of years. But the Lancet report estimated this population attributable fraction, which is related to, the risk and then how prevalent that risk factor is in the population from epidemiology studies. But there was other evidence from longitudinal cohorts that, dementia may be preventable. And here are data from the Framingham Heart Study. And this study, as you all are probably very familiar, started in 1948, and a few decades later, they started adding in cognitive outcomes to to their visits. And in looking at the cognitive outcomes over time, and they look at these epochs is what they call them. And so, okay, this group of people, and this group of people, this group of people, they were finding that the incidence of dementia was going down as over time. And a couple of other cohorts have replicated this, but so again, that was kind of in line of like, okay, maybe, better treatment, the statins that have come out, and, we know about blood pressure now, and people are smoking less. Maybe this is just incidentally going to, incidentally, pun intended, make dementia, less of an issue over time. But I don't think that we can quite rest on our laurels and keep up just our business as usual. And the first reason is that, I'll get in more into this on the next slide, is we don't know if this is true for the whole US or global population. And that's just because incidence is so hard to estimate. It's hard to find people. And data harmonization is tricky, as are distinguishing what's a cohort effect. So this, the Framingham is a really well phenotyped cohort, but they live in a particular place. Or distinguishing it from secular trends, that people are just generally smoking less, they're generally moving more. I know the dementia, I don't know if anyone here is working on the dementia risk prediction pooling project that's led here at Northwestern, but I know this data harmonization and looking at trends is a big job. And the second reason that I don't think we can rest on our laurels is because better treatment of vascular risk factors doesn't account entirely for this trend. I didn't actually include the table from another Framingham study, but they said, okay, is this because of, hypertension getting better? Is it because people are having fuller strokes? Is it because diabetes? And they controlled for all those things. And it wasn't that the trend just went away of, oh, okay, it's going down because people are having fewer strokes. So there's more to the story here. And dovetailing that, and this could be the topic of a whole separate talk, but medical interventions in late life to prevent dementia or delay dementia have not really yielded the robust results that we may expect based on that long list of factors and how much of an impact they have. And there's a lot of reasons for that. I mean, it may be the time of life, but I'm thinking about results from studies like the Accord Mind or the Sprint Mind trial, or even, kind of long-term follow-up from the original finger study where they say, okay, maybe, medical intervention isn't going to be the whole story here. So we probably need to look at the life course when we think about prevention, and we probably need to look beyond just medical treatments. So about not knowing the true incidence and prevalence, other studies have looked at a more diverse or representative US sample and found that we may be underestimating the lifetime risk of dementia. And these are data from the atherosclerosis risk and community study, which shows estimates of lifetime risk based on, I think it ranges, but about a median of 23 years of follow-up. And as you can see, the lifetime risk, I glossed over this on the last one, but in the Framingham study, they said about 13% for men had a 13% risk of, or lifetime of developing dementia for men, and 20% for women. As you can see, this number is much higher in the ERIC cohort. And the ERIC cohort is more diverse, about half Black, half white, and it's a national cohort. So it's representing a broader range of social, economic, geographic environments. So we can expect some difference there, but it's really pretty stark. I mean, it's over double what the estimates for the Framingham study were. And we're starting to see that when you stratify by gender or sex or by race, you see some differences emerging as well. But there's a couple reasons, just to get ahead of the question, there's one, the ERIC study is finding more dementia. It may be because they're looking at a bigger population or a broader sect of the population. But they're also the study design itself is fastidious in finding people. So they try to mitigate the selection bias from cognitive decline. So people not attending their study visit because they've had some cognitive decline. by doing phone interviews. So if someone doesn't show up, they call them up and say, hey, how are you doing? Or they talk to their care partner and say, hey, how are they doing? And then they also have a way of looking at hospital records and ICD-10 codes, healthcare records, basically, to see what happened. So they're um, they're finding it, and then, but also, when I talk to people who work on ERIC, they're like, this also might be an underestimate because even though it's a generally, people in the ERIC cohort have a lot of comorbidities. They're still generally healthier. Cohort people who volunteer for cohorts are generally healthier um, than the average population. So this even might be an underestimate. So we don't estimating incidence would be really cool to do, but we're probably going to be underestimating it whatever we do. But anyway, so we see differences. We're seeing, okay, when we look at a bigger group of people from diverse, social, economic, geographic backgrounds, we're seeing some differences. Um, but then also, thinking about exposures, quote unquote, beyond medical disease. And of course, I'm going to land this ultimately in the physical environment, but I just wanted to show this study of uh, socioeconomic status and cognition. And so this was a study that took data from both the health and retirement study, which is a US-based study, and then the English longitudinal study of aging over here on the right. And they stratified by socioeconomic status and looked at cognitive trends over time for up to about 15 years. And as you can see, there's differences in cognition already when you stratify by socioeconomic status. And in some cases, there's differences in trajectory of cognitive decline. And they were like, okay, well, we can all come up with hypotheses of why that is. If you maybe you have more medical comorbidities, or you're not exercising as much, you're not sleeping as well, your diet isn't quite as good. And they found when thinking just about lifestyle, that only accounted for about 15% of the difference um, in cognitive decline. And so there's something beyond just what you're doing, the individual health of somebody, something beyond that that's affecting how people age cognitively. And this is unsurprising, for clinicians in the room. We all know that there's a lot of variability in aging. When we see people in the clinic, you're like, yeah, I can't quite put my finger on it, but this kind of makes sense from what I know about your background. And so it's hard to ignore these patterns, and I think that they're worth studying. So when I look back at this modifiable list of risk factors, not only do I see, okay, there's a lot more beyond just the individual health, but then I see that they're kind of quickly backing up against societal structures that are influencing our environment. So we're thinking about air pollution here. You can have you can have air filters in your home and everything, but you don't have that much of control over the amount of air pollution that you're exposed to. That's really influenced by policy and regulation. Education, again, there are some individual factors that affect how much education somebody pursues, but definitely there's a lot of social and political factors that go into education level. And then there's other things. I mean, physical activity, we can, talk for a whole hour about how social and economic forces influence how somebody can or cannot do that. And just to really drive it home, I do think that policy has a big, as we're backing up and saying, okay, if these social, environmental things influence our health, what is influencing behind those? Why behind that? What are the policies? And so we think about financial and tax policy. And so this is a graph that I pulled from the Center on Budget and Policy Priorities, which just takes numbers from the CBO. And you can see that very wealthy people have gotten a lot more wealthy over the last 40 years, and it has not been the case for the rest of people in the United States, at least. And then when we think about what we're exposed to, that is dependent on where we live and what's next to where we live. This was a book that came out in 2017, right when I started residency. I read it because I think it was right before I started residency, so I had that nirvana fourth year after you've matched, but before you've started, where you can read things. This was a really nice a book just about going systematically through social and housing policy and how that was influenced. Policy is always downstream of culture, and the culture of the early 1900s was deeply rooted in racism. And then saying, okay, we can point to all these things, but can we measure that too? And this was a study where the author or the investigators looked at air pollution exposure by race and not just how much people are exposed, but then also the sources of exposure. And I know that the sources are far too small to read, but it's unsurprising that there are differences by race. So the other tool that has come out in the last 10 years or so is the Area Deprivation Index. So this is, again, giving tools to health disparity researchers to say, why is this happening? We see these disparities, but why? And where could we take action? So I'm sure many of you are familiar with this. It's called the Area Deprivation Index. It was developed by a group of researchers led by Dr. Amy Kind at UW-Madison. And they go by census tract, but they estimate the degree of kind of material and financial when that translates to social deprivation, based on income, area income levels, housing prices, vacant house. I know they're continuing to iterate on this vacant housing, industries that are there and come up with this uh, degree of disadvantage, which they call neighborhood disadvantage. And so this is just the map of the state of Wisconsin, but this is available for the whole United States. I did have the opportunity to meet with Dr. Kind when I was at Madison, and she was a core value of hers was data democratization. And so she was like, yeah, I want to come up with this because I think we really need this to help our research and to help our policy. But I really want to make it so that everybody can use it. So it is available on their website, and they just want you to cite them when you use it, if you use it. Or I'm sure they'd be open to collaborations as well. This on the right here is a study that used the Area Deprivation Index to look at hippocampal volumes. So just demonstrating that in the most disadvantaged neighborhoods, hippocampal volumes when we look at brain tissue are smaller. So this is from actual brain tissue, not just MRIs. As a as a side note, but there was a Wisconsin alumni magazine that I got over the weekend. It featured Dr. Kind's her lab's work in developing this, and they made a point in writing about how this not only is used to like describe or account for the disparities that we see, but also to be really targeted as far as, okay, well, if we're going to intervene and we have limited resources to intervene, where do we do this? And so Milwaukee's right around here. Y'all are from the Midwest, you know. When I give this talk in Texas, or when I talk about this in Texas, they're like, Wisconsin or Madison's here, Milwaukee's here. The Milwaukee Water Department. I'm sure many of you saw those stories a few years ago about the lead pipes in Milwaukee causing, big problem. And they're like, well, this is a huge job to replace all of these. Where would it be best to replace them? And they were using the Area Deprivation Index tool to target neighborhoods or to say, okay, these are the really high yield, most disadvantaged neighborhoods that would benefit the most from having their pipes replaced. But anyway, I got on a total tangent. So we covered the epidemiologic why, or I hope that I made it clear the epidemiologic why we should be thinking a lot about the environment. And that could really be broadly defined. I'm focused on the physical environment, but really broadly defined when we're thinking about healthy aging and unhealthy aging. So we cover the science, and now I want to talk about the community why. So now I'm going to talk a little bit about where I am in Texas. So the prevalence of dementia is certainly increasing. It's like sentence one on every single dementia-related paper. But it's really prevalent in South Texas and these counties down here. San Antonio's like right here. So this is from a paper that just used Medicare data. So, all the limits that go with that. But, incidence is pretty high, prevalence is really high. And we don't know exactly why the prevalence is so high. in South Texas, there's a lot of hypotheses. I mean, one is that it's an older population. This is from the Texas State Comptroller, just looking at, how people are moving around. And Texas is generally a state that's getting older, as is the whole United States, but and South Texas is certainly no exception. There's a very high Hispanic population. This might be too small, but it's about 85% Hispanic. In the limited Hispanic studies that we have, they're about 1.5 to 2 times as likely to develop dementia. So does that account for it? Could there be a unique genetic risk? There's a group of researchers here at our ADRC that have done ApoE genotyping on our whole cohort. And they found actually that the ApoE4 allele is less frequent in this population than it is in the other populations. So there are, of course, other genetic risk factors or risk genes for Alzheimer's and dementia, but at least for that one, they're like, okay, that doesn't fully explain it. There could be more medical risks. So diabetes and hypertension, heart disease are prevalent here. So it could be explained by that. It could be a misdiagnosis. There's a lot of discussion about how, the cognitive batteries that we use may over diagnose cognitive impairment and dementia, or cognitive impairment in particular, in non-white populations. And then, of course, I'm always wondering about environmental exposures. Is there something unique to this area that may be causing more brain damage, brain injury? So what do we decide to study? There's so many things, and every single thing probably has value. But I want to talk for a minute about community engagement. And this is an organizing paradigm that I think for me made intuitive sense pre-medical school and then kind of faded from consciousness as you're doing that marathon sprint through medical training. And now, for so many reasons, is back as an organizing frame in my clinical work and then research. And this picture is just a screenshot from a local news story, but the story was highlighting the community engagement and organizing work that's led by Dr. Sara Doyle here at UT San Antonio. And she and her team have collaborated with communities in South Texas to put on a series of these, they call them pláticas, or community conversations. And these center around the experience of dementia and caring for someone with dementia, and then identifying, research priorities and priorities for, care in this population where there's some counties where 25% of people have carry the diagnosis. And in these conversations, the environment comes up a lot as like, is there something in the water, in the air? There's something going on here. And that's for good reason. I mean, this graph this map on the left here is a map of Superfund sites. So these are funded by taxpayer dollars, but there was a fund set up in the 1970s basically to clean up pollution if the company, was no longer in business or no longer around. And so there are a ton of Superfund sites in South Texas, a lot in Houston, unsurprising, a lot of oil and gas, a lot in San Antonio, some oil and gas, and then some other compounds which we can talk about later. Most of these are oil and gas down here, but then there's also, there's a lot of agriculture down here. So this one out here is a pesticide storage tank that was in the ground that had leaked everywhere. So Texas processes about a third of US oil. So that is a big concern about pollution. Agriculture is a big industry, so a lot of talk about pesticides. And then air pollution is also top of mind. These graphs on the right came from the American Lung Association State of the Air report, which just came out in April. This one, Brownsville, which is right around here, was number 2 as far as the most air pollution when they looked at the whole United States. McAllen, which is down here on the border, was number 17, I think, of all the counties in the United States. SpaceX, which we can talk about in a second, just started their launching here, their explosions there. So again, where these come from is um, a conversation for another day, but for good reason, I think, in these community platicas, environmental pollution and its relationship to overall health, and then particularly brain health, because that's what these conversations are about, comes up a lot. Um, just highlighting again that air pollution is a big problem. Part of my project is looking at air pollution and cognitive trends in our South Texas cohort. So when we just did an initial like exploratory poll, these data are from 2020, and we did a GMM, the generalized, I'm forgetting what the acronym stands for, to look basically like, are there clusters of air pollution exposures? And in these top two categories, everybody here lived down on the border, so down in those areas where the American Lung Association reported that there was really significant air pollution. So there's a community-based why as well. Studying the environment, I think there's good epidemiologic reasons to do so. It's a priority for the community, and we need that trust. So I just want to briefly touch on the era. I mean, we live in the internet era. There's an epidemic of misinformation and disinformation, and the fear-mongering and misrepresentation of science that goes with that. And generally, the public does not trust institutionally associated researchers. This is polling from the Kaiser Family Foundation just from a few weeks ago. Um, so that's kind of a busy slide, but basically saying, who do you trust to get health information or information about health issues? And there's so many in the news now. For all the clinicians in the room, your patients really trust you. So your individual work on a daily basis, answering questions about Preventive or counseling on getting your shingles vaccine, like that really matters. And unsurprisingly, trust has eroded pretty much across the board, but also along party lines in the CDC and state government officials and the FDA. But, building back trust in science and building back trust with, all of us who are doing really wonderful work to advance the health and healthy aging of our communities, there's a lot of work to do. I will step off my soapbox now. So anyway, let me talk to you briefly about my study, and I will fast forward and say I don't have any results yet. By the end of this month, I should have all of our blood test results back, which I'll talk about in a second, but I have no results to present to you today. I'll have to come back to do that. But let me just tell you about what we're doing, and then we can have ample time for questions. So my study is pretty simple. It's looking at environmental pollutants, exposure to environmental pollutants, and then their relationship to cognitive aging and brain structure in our Alzheimer's Coordinating Center cohorts, our ADRC cohort. Our ADRC is a collaboration between, UT Health here in San Antonio and then UT Rio Grande Valley. So we recruit participants from both sites or both centers. And 13 South Texas counties are among the top 25 in the US with the highest prevalence of Alzheimer's. So underscoring what we talked about earlier, just this is very prevalent where we are. It's a big public health issue. It's top of mind for researchers and for community members. And so this study is a simple epidemiology study. So we're going to measure the PM, the particulate matter 2.5, so that the small particles in the air, which have probably the most studied connection with dementia. We can talk about that in a second. For at enrollment, so our center started enrolling participants in 2021, and then also looking back 10 years prior to enrolling. And then also doing an assay of blood at enrollment that looks at about 70 plus xenobiotic pollutants. And then in the second two aims, we'll look at the exposed and unexposed and see if there are differences in MRI markers of brain aging and then cognitive outcomes. So what are the pollutants that we are testing? There are 70 plus, I think it's like 72 that we're testing directly for and we'll measure the level of. And then there's also an untargeted high resolution mass spec assay, which is, as agnostic as you get. At a certain point, it's turtles all the way down, but thousands of things. And there's a couple just based on what I know we have, we're currently cleaning up or have cleaned up in the past that I'm excited to see if those show up. But there's 26 heavy metals. They have some of them obviously have known neurotoxic properties. So thinking about manganese and Parkinson disease, mercury, nickel. In my pre-test probability of what do I think we'll find or what do I want to pull out if we as opposed to just, it's a small study. So if there's anything that's going to be high yield, I do think mercury and nickel may be high yield. SpaceX has been cited and sued a number of times for not properly disposing of its launch water, the deluge water. So the way that works is they launch a rocket, and obviously there's a ton of heat that happens with that, and they just put water all over it to dissipate, basically to be a heat sink. But they have not, and it's full of mercury and full of nickel, but they haven't disposed of it properly. So the Texas Commission of Environmental Quality, TCEQ, has cited them a number of times, as has the EPA before times. Organochlorpesticides. So there's a lot of agriculture in South Texas, but this group includes things like DDT, which even though it's been outlawed since the 70s, it doesn't really break down. Heptachlor is another one that's no longer legal, but doesn't break down. This one has links to Parkinson disease. And then atrazine is still used. Atrazine and simazine are both still used in this assay. Polyaromatic hydrocarbons, so these are basically from petroleum processing. So I think that'll be interesting to see based on the industry of South Texas. Polybrominated diphenyl ethers. These are flame retardants and insulation. They are a lot of states have banned their use. Texas has not, but they can be found in wire insulation and in cars. So, but again, similar to the other ones, they don't break down. Polychlorinated biphenyls have been illegal for a long time, but they persist in the environment. And then the untargeted high-res mass spec assay, it will test just for the presence or absence of a lot of different compounds. The one that I'll be looking out for in particular is trichloroethylene, because there's 2 sites in San Antonio that are still actively cleaning that up from leaking into the groundwater. So how are we going to measure this exposure? We're going to use a algorithm or a method developed by the Atmospheric Composition Analysis Group at WashU in St. Louis, similar to the ADI and Dr. Kine's lab. They have just made this method available. And so it combines information from chemical transport modeling, satellite data, and then ground-based monitoring. So the EPA has sensors all around, and then some, machine learning, hand wave. But interestingly, they're able to go, or what they've developed is being able to go back. And so they've got data all the way back to 1981 and have pretty high resolution, 1 kilometer squared for monthly particulate matter levels. They also have, for anybody who does international research, their big goal, and I think their driving goal would be to, hey, can we come up with a model so that we can estimate air pollution in places that don't have as many ground level monitors like the US does? If anyone is interested, this is their website. And then our other outcome, so as far as so the blood assay, those results are due out at the end of the month, and then the air pollution, we're just estimating based on the zip codes from our participants. And then our outcomes, the first one is to look at brain aging, and so, or brain imaging. And I was counseled by some people who have been doing air pollution work longer than I have to keep the outcomes pretty general. There was an earlier meta-analysis of air pollution and brain imaging. And the authors concluded that um, basically it's better because we don't know exactly how, we don't fully understand how neurodegenerative disease um, happens in individuals. But then also we don't exactly know the relationship between air pollution and neurodegenerative disease. And so they recommended being much more general in your markers that may reflect an underlying etiology rather than something specific. So instead of looking at just the thalamus or just the basal ganglia, look at, uh, deep gray matter, or look at total brain volume, or look at total gray matter volume. So that's what I elected to do here, was be pretty simple with the total brain volume, controlling for intracranial volume, cortical volume, the size of the ventricles, white matter hyperintensities, and infarcts kind of as a surrogate measure for, is there a vascular component to this? And then the exception is the spare BA and spare AD indices. And these two outcomes on the bottom are a little bit newer. They stand for the spatial pattern of atrophy for recognition of brain aging, the first one, and Alzheimer's disease, the second one. And these are quantitative indices that were derived from multiple longitudinal studies to better quantify advanced brain aging. I don't know how many of you have tried to, talk to the patient about when the radiologist says like there's mild generalized atrophy, and they're like, what does that mean? My brain's shrinking? That's bad. And I've never really felt, I'm like, yeah, I've never felt equipped to really be able to quantify that or predict anything for a patient with that. Outside of general terms of, we look at the hippocampus and that may predict future cognitive decline. But Dr. Habees is the director of our imaging core at the ADRC here. This is Mohammed. He developed this quantitative algorithm using multiple cohorts, basically as a way to say, hey, can we quantify how much your brain has aged relative to everyone else? So that is one of the outcomes that we will use. In addition, quantifying better, what are the brain changes that you see with Alzheimer's disease? We use these outcomes a lot at our center because of Dr. Habees. I don't know how ubiquitously they're used elsewhere, but it'll be interesting to see. And then the other outcomes is our cognitive testing. This is pretty straightforward. So we use the uniform data set version 3. So we'll use a composite score from the executive function and the memory score, and then the adjudicated clinical diagnoses from our consensus conferences. Looking just at the sample initially, in our sample of 200, so there's 200 people who were able to pay for it to get the blood sampling because it's pretty expensive. 77 have normal cognition, 75 have mild cognitive impairment, and 48 have dementia. So a pretty good range of the cognitive outcomes. So let's talk about the study limits. There's so many. I mean, the first one is that it's small and probably underpowered. It's a pilot study. But there's also a lot of assumptions that we're making. The first one is for air pollution, and this is a problem for every air pollution study, is that, does your external air, the air that you breathe, the air that's outside of your home, your immediate home, does that equal your internal air? And that may or may not be true. People use air filters. HVAC systems have filters just in them to begin with. You may be spending 12 hours a day at work. You may work 30 minutes away where their quality might be a little bit different. So, we can come up with a lot of them. Another one is that, with limited resources, again, you have to make stronger assumptions. And even in our study saying, okay, we're going to not just measure your air pollution at enrollment, but try to go back and estimate what you may have been exposed to over the 10 years prior. And people may or may not have lived in their home for that long of time. So that may or may not be true. Demonstrating this, but it's a big lift, right? To go back and say, I'm going to call each participant and get their residential address for the last 10, 20 years. But when you do that lift, you get pretty cool, it can be worth it. I'm bringing this up. So this is a study, an air pollution study that was done with the Ginkgo Evaluation of Memory Study, the GEMS study. And this is a busy slide, but they literally called people and then also used LexisNexis to say, okay, where have you lived in the last 20 years? So they were able to get much better resolution of what people have been exposed to over time. And then they had their cognitive evaluation with the GEM study. Um, they did find a pretty among the stronger associations. So when you do the work and you look for the exposure, that may be true. But they also found that people are pretty mobile. So when they were looking at their addresses, these dots, so the bottom one is 1980, then it's 1989 in the middle, and then 1999 on the top. These dots are where people have lived. And so they were all over the country. And then eventually by 1999, when the GEM study started, they were living in the places where the study started. So the assumption, I think, that people haven't moved may or may not be true. It probably depends on a lot of things. But you can also see here too that air quality has generally gotten better. There have been headlines recently that with climate change and wildfires, this trend may be reversing. And I think that's another reason we should really understand this relationship with brain disease. But this is another reason why it's hard to separate, what's the time trends, the secular trends, can be challenging to differentiate from true effect in cohort studies. And then another, limited resources, stronger assumptions. The blood levels are easy to get, or they're relatively easy to get, and you just have to draw some blood. But they may or may not represent chronic exposure. I can spin a story, an argument for both. One is, okay, if you're living in the same place and you're eating the same food, drinking the same water, breathing the same air day in, day out, yeah, your blood level's probably not that different. But of course, you can say the opposite and say that really just measures maybe the last couple days, depending on how much you metabolize things. And so the, more time, more money and more time, the better data you get. And so, one example was with the GEM study where they had the personnel to find those prior addresses. More money might get you tissues that reflect chronic exposure. So a lot of these accumulate in fat. So can you do a fat pad or other way, kidney biopsy to assess chronic exposure? But or can you convince somebody who has biobanked blood that this assay is really high yield, really worth doing? I want to see my results before I go seeking out precious biobanked blood from somebody. And then of course, there's so many unmeasured confounders for a late life outcome. And I think this is a challenge for all aging and dementia research that, it is such a late life outcome, going back and saying what influenced that. And was there something that a more proximal outcome that someone died of a heart attack instead, and you're finding that high air pollution is protective or high LP(a) is protective, and really what you're saying is there's unmeasured confounders. So there's a lot of challenges to this, and then we haven't even gotten into the causality part. So let me just talk briefly about what we do know about these exposures, and then we'll wrap up. I know we're getting close to time here. So just briefly for air pollution, there's been a lot of studies over the last decade. There seems to be an increased risk, particularly for particulate matter 2.5. Other things that they've looked at are bigger particulate matter, so up to 10 microns, nitrous oxide or the nitrous dioxides, and then ozone or other common pollutants that people have looked at. Study design limits are getting a good study design is hard. And the next slide, we'll talk more about this. And then the mechanism is still unknown. There's a lot of hypotheses of, is it vascular? Is it neuroinflammatory? Is there oxidative stress? Still unknown on there. And then for the xenobiotic toxic exposures, we know quite a bit less. There are stem cell models, there are animal models that say, okay, yeah, if you expose a rat to this high level of X, It's bad, but of course, translating that to humans is a lot more complicated. There have been some case cohort studies and some cross-sectional studies, which I'll talk about in just a second. But again, it's a big list of things, so we can't get into everything, but the mechanism um, is still unknown. So for particulate matter 2.5, this was a really nice meta-analysis that came out a couple years ago that looked at air pollution studies, because like I said, there's so many, and differentiated them, parsed them as ones that used active case ascertainment and then ones that used passive case ascertainment. So that would be like healthcare records, ICD-10 codes. And they found that the relationship was consistently stronger and more consistent with active case ascertainment. And the authors talk about how, well, with passive case ascertainment, you probably have some bias, but it's probably biased towards the null. Um, and so, in future air pollution studies, if we want to, unless we're going to have a huge, huge sample, which that's harder and harder to get, having active case ascertainment is probably better. And the bias towards the null makes sense. Using ICD-10 codes, that code may have been entered because you needed to get a PET scan approved. It's never made sense to me why you put in Alzheimer's disease to get an amyloid PET, but I don't know if they have Alzheimer's disease. That's why we're getting the study. But there's many other things where a code has been put in for a referral or put in because it needed a test approved and it wasn't the final diagnosis. So I had never seen a study kind of differentiate stratify by case ascertainment, but I think that makes a lot of sense for dementia studies. For polyaromatics hydrocarbons, I pulled this out just because, we're in Texas, and because I wanted to review my organic chemistry again. These are what they look like. It's just a bunch of benzene rings put together. The ones that we are looking at are these ones. They basically come from incomplete combustion of organic materials like coal, oil and gas, garbage. They can also be found in tobacco or charbroiled meat, and you can inhale them. They can be absorbed on your skin. You can ingest them. Importantly, just as a note on the industry, so the oil and gas industry does regulate some of their emissions related to human health, and the big ones that they do it's called BTEC, so benzene, toluene, something that starts with E and then xylene. So these are much more regulated. They have much clearer links to things like leukemia. So these are not included in the assay. I am curious to see if they come up in the high-res mass spec assay, but I know that the industry itself regulates itself more on those. There's very few studies in adults, particularly older adults, on hydrocarbons and neurodegeneration. Most available studies use urinary samples. And interesting, I don't know if this has been replicated, but there's been a couple studies that have said, okay, we see these in the urine. They may have more variability than when you measure them in the serum. So there's been studies that look at both urine and serum. Biologically, that kind of makes sense. People metabolize things differently. Now, which one is more important to measure, I don't think that we know. But in cross-sectional studies that have used the urinary metabolites, so hydroxylated hydrocarbons, they do find a negative association with cognitive studies. And there's one that uses NHANES data and then one that is in Korea. And I think they're planning on doing more long-term follow-ups. I'm excited to see what their findings are. And then the last one that I'm curious to look at is trichloroethylene. I drew this out because there's 2 active Superfund cleanup sites here in San Antonio. Trichloroethylene has the clearest link to Parkinson's disease, which is obviously not the focus of our study, but cognitive decline can be part of that syndrome as well. Probably the most famous pollution with trichloroethylene was at Camp Lejeune in North Carolina, a Marine base. and the groundwater there was contaminated with super high levels of trichloroethylene from a nearby dry cleaners for years. And a case cohort study found that the veterans who lived there had about 70% higher risk of PD over this following 40 years than veterans who had been at other Marine bases like Camp Pendleton and in California. So I'm excited to see, did people have this in their blood? So in summary, I think toxic environmental exposures may be a contributing mechanism to health and the aging disparities we see, but it's so tricky to study. But it's important because it's a priority for the communities we serve, and how can we translate our findings to support their, or really our, collective action regarding healthy environments for healthy aging? Because transforming our environment could be true primordial prevention. But even though I'm laser focused on this, I know there's no shortage of things to study and work on. So with that, few minutes left. I just wanted to thank our, funder. So I'm an RL5 scholar with our Pepper Center here in San Antonio. I don't think any of my mentors are here, but I would thank them. They're from both here in San Antonio and then down at Rio Grande Valley. And also my academic home is at the Biggs Institute here, and they have been super supportive of me being a young research faculty. So with that, I will take any questions.
Thank you for such a great talk. So interesting, a little bit scary, but very interesting. Um, let's see if we have any questions. We aren't having folks unmute, but you can put your questions in the chat. If you have anything for Dr. Doyle. I am not seeing any questions. Very interesting work, and I can't wait to hear the next steps and the next what you find.
Yeah, I'll share updates as we have them.
We'll have to have you come back.
For sure.
Well, we really appreciate your time, and thank you everyone for joining us for this month's Pepper Rounds. We'll look forward to seeing folks this summer. Last call for any questions. Thanks again, Dr. Doyle. We appreciate your time.
Yeah, thank you.